A very good afternoon, ladies and gentlemen.
Warmly welcome the Chancellor of Gomel State Medical University, Belarus, Professor Igor Oligovich, Stoma, Vice Chancellor of General Sir John Kotalavala Defence University, Rear Admiral HGU Dhammika Kumara, VSV, USP, PSC, Deputy Vice Chancellor, Defence and Administration of Kotalavala Defence University, Brigadier R.K. A.R.P. Ratnayaka, RSP, USP, PSC, Deans of Faculties, Directors, distinguished invitees, and ladies and gentlemen. A warm welcome to all of you to this very special occasion, the CME and the initiation of the MOU between General Sir John Kotalavala Defence University and Gomel State Medical University. Now, before we start things off, ladies and gentlemen, of course, let's all rise for the anthem of KDU. Please remain standing, ladies and gentlemen, because we are now about to pay tribute to the fallen war heroes who are not, of course, who didn't just write off their debts, but gave their very deaths to the future of this country. A minute of silence for the fallen war heroes. Thank you. Ladies and gentlemen, I'd like to still ask you to remain standing because it is tradition to start things by the lighting of the traditional oil lamp. For this, I'd like to most respectfully invite the Chancellor of Gomel State Medical University from Belarus, Professor Igor Oligovich Stoma, the chief guest, and of course, Vice Chancellor of General Sir John Kotalavala Defence University, Rear Admiral HGU Dhammika Kumara, Deputy Vice Chancellor, Defense and Administration at the Kotalawala Defense University, Brigadier R.K.A.R.P. Ratnaika, Dean, Faculty of Medicine, KDU, Professor Aindralal Balasurya, Director, Medical Services at the University Hospital of the Kotalawala Defense University, Brigadier P.S. Tilakaratna, Director, Administration at the University Hospital of the Kotalawala Defense University, Brigadier C.S. Tibbatuge, Deputy Director, Administration, Colonel L.C.S. Muthukumarada, Deputy Director, Medical Services, Surgeon Captain M.V.S. Atukorala, and Consultant Neurosurgeon and CME Coordinator, Dr. Charit Tanayakara, to light the traditional oil lamp to start things off. Thank you very much, ladies and gentlemen. You may now take your seats. To start things off, we have a beautiful dance that is ready for us. But of course, we're starting on a note that is very important, a note that this significant event will turn the pages not just of the history books, but also of the books of the future. Ladies and gentlemen, a beautiful dance to welcome all of you. Thank you very much, ladies and gentlemen. Can we have a round of applause for that, if that is fine? Quite the welcome, and that welcome is indeed deserved, ladies and gentlemen, because as I welcome all of you to the CME and the initiation of the MOU between General Sir John Kotalavala Defence University and Gomel State Medical University. A very important day for all of you. But I'm going to start with a small story for all of you. There was once upon a time a Hungarian physician. This Hungarian physician, you might know, is someone who always found something different compared to his peers. Now, a lot of mothers were dying from childbed fever. I'm sure a lot of you know this story. But while the mothers were dying from childbed fever, they couldn't realize why this was happening, because doctors were apparently doing autopsies and then delivering children from mothers. The small change that this particular physician found was that they were simply not washing their hands, not sanitizing, before they did both. However, this fever continued because they didn't change their ways. They ignored this physician, and continually this physician died because people ignored his learning, his wisdom. What happens when learning is ignored? When wisdom itself is ignored? That, ladies and gentlemen, is what we're here to not do exactly. We're here to learn, to commit to a future where education itself becomes the passport for the future, as Malcolm X has also very widely said. And with that future, we are here today, two very well-recognized universities coming together for something extremely important, the pinnacle of medical collaboration, if I may, because learning is something that never ever stops. And that is why continued medical education, the CME, especially today's one, is very important, because we are not just having one, we are also initiating the MOU between KDU and the Gomel State Medical University. And with that, ladies and gentlemen, I'd like to invite our chief guest for this afternoon for the lecture on microbiome studies in medicine, clinical applications, and challenges. Ladies and gentlemen, let's welcome the Chancellor of Gomel State Medical University from Belarus, Professor Igor Oligovich Stoma.
The presentation is there. Is there. Dear distinguished guests, Your Honor, dear Admiral, and all of the distinguished officers that are here today for this memorandum of understanding and for the lecture, I'm honored as a chancellor of one of the leading medical universities in my country to be here in Sri Lanka and to be here at your excellent university and your university hospital. I've already seen that you have wonderful and very serious possibilities to educate our future medical doctors and our future military doctors. From my side, it is important to underline that our university is also giving a military medicine education. One of few universities in our country, Gomel State Medical University, has a department of military medicine. That's why all of our boys, males that enter our medical school, they undergo the program of getting the position and the official rank of the lieutenant of medical service. So they go not only surgery, not only therapeutic medicine, they also went to the special military department to train in military disciplines. That's why every medical doctor that graduates, male medical doctor, he becomes a lieutenant by the order of Minister of Defense of Republic of Belarus. That's why we have a lot of common. And myself, I'm also an officer of medical service, being a chancellor of medical university. So I'm happy and honored to be here in this day. And one more important thing to say before the start of the lecture, we are signing our Memorandum of Understanding in very important historical day. I would like to mention the 9th of May is the day of the victory over the Hitler coalition, over the Nazis in the Second World War. So the Second World War was officially finished in the 9th of May of 1945. And this war took a lot of human lives. For Belarus, every third national of our republic was killed during the Second World War. So in every family, there were people who were fighting as members of the army or as partisans against Germans. So in this coalition, we have won, and the 9th of May is the symbol of our victory and the symbol of remembering all the losses in our country. So I believe this is the important day for signing the Memorandum of Understanding. Let's applaud for the victory. And basically to give you the understanding of the topic of my lecture today, I would like to say that I'm a physician. Yeah, so I'm a physician of infectious diseases, the infectious diseases physician, and the clinical microbiologist. That's why we're going to talk today a lot of things. But I would like to start to say some things about COVID-19. So I was in charge as an infectious diseases professor in the consultative group to our president for strategic decisions in COVID-19 pandemic. And it's interesting to underline that there were actually only 2 countries in the world that didn't go for a lockdown. It was Sweden and Belarus. So we had no lockdown during the COVID-19. Our universities were fully working. We didn't go online. We went offline as usual, just stopping the lecture halls, and all the practice in surgical rooms at hospitals were going on. Also, all our factories were working. So the country didn't stop during the COVID-19. And in the end of the pandemic, we understood that this was the best decision because we could provide hospital beds to all of the patients with COVID-19. Due to the Semashko system of healthcare, the Soviet system of healthcare, we have a large number of hospital beds, excessive number of hospital beds, because our healthcare is totally government funded. So all healthcare in our country for citizens is for free for citizens, starting from dentistry to organ transplantation. You can receive organ transplant for free. You can receive all operations for free. That's important that pharmacies are for free when you're in hospitals, and education for the citizens of Belarus in our medical university is also for free, and it's important that we give high quality education there. So this excessive number of hospital beds helped us to provide oxygen, to provide treatment to every patient with COVID-19. And this is important that when we have done this, we understood that there was no necessary lockdown in our country. So right now, I hope I will switch on the lecture here, if somebody will help me here. So yeah, I think it will go here. Is it on the slides? I'm not, oh yeah, it is there. So this is the picture. I start my lectures about microbiome and infectious diseases. This is quite an intriguing picture here. You can see the foal, newborn horse, which has a natural instinct. People who have horses at their farms or veterinary specialists know that the newborn foals, they can stand on their feet. Humans cannot. Yeah, our newborn babies, they cannot do anything except crying, yeah? But foals, they can stand. But they have some problems with their immune system. So their immune system is underdeveloped, and actually this is the instinct they have across all the world. They try to eat their mother's poo, you can see here. So they smell it and they eat it. The biological idea of this instinct is to form immune system in their gut, because their immune system is underdeveloped. They take the immune system from their mothers, take it to their gut, eat it, and that's how they fight the infections. That's why they survive the first year of their life. So actually, that's what people do when a newborn baby is born. What you do first, yeah, after you cut it, yeah, you put the newborn baby on the breast of a mother. You establish the psychological, the emotional connection with the mother, but not only. You establish the interchange of microbes. So the mother gives her own skin bacteria to the newborn baby, and that's how the immunity forms. So that's a very important story here. And here you can see on the slide, actually you can see how the bacteria in the gut of a newborn baby develops. So from day 0, yeah, you can see here till the few years of life. So different colors are different bacteria. And you can see that at the start it's very similar, firmicutes. Then goes proteobacteria, then actinobacteria. And when you start to feed the baby the adult food, like from the table of the parents, the bacteroides come into play. Why it is important to live with microbes? Each of you have trillions of microbes in your gut, in your skin, in your throat, in your lungs. It's necessary. Interesting statistics. So on the left side, you can see the incidence of type 1 diabetes in children in different countries of the world. So you see here, high incidence goes to Northern America, yeah, to some Scandinavian countries, and lower incidence goes to Africa, Asia. When we talk about tuberculosis and diarrheal diseases, it's opposite. You can see that diarrheal diseases and tuberculosis, it's in Asia and Africa. So it's interesting that there's so-called the civilization theory or the hygiene theory of autoimmune disease. So, you know, in Scandinavia, in Europe, there are a lot of diabetes, multiple sclerosis, asthma, atopic dermatitis. But in Africa, for example, you don't find these diseases. You find diarrheal diseases. So it's interesting that every child has to fall ill with infections for a certain number of times for his immune system to be developed, for his immune system to be calibrated. Because immune system, it's like your muscles. If you want to have good muscles, you have to go to the gym. You have to train your muscles. If you don't train your muscles, they won't work. The same with the immune system. If you don't train your immune system with bacteria coming from outside, your immune system will not know how to work properly, and it can attack actually your own organs. It can attack your lungs with asthma. It can attack other systems, your neural cells, etc., etc. So when people ask me, is it good to maintain sterile condition in a family and to wash hands in children like 20 times a day? I say no, it's not necessary. So it's good when children play in the street. It's good when children play with cats and dogs, with animals. They exchange microbes. From modern points of view, it's good. And now I'm going to talk about problems. So bad bugs and no drugs. That's actually the slogan of the last decade. We are losing our antibiotics because of the antimicrobial drug resistance. This is the invisible pandemic that we do not see, actually, because we have seen COVID-19, but no one sees the antimicrobial resistance in the hospitals. Why? Because from clinical point of view as a clinician, it's very hard to distinguish a patient if he has an infection caused by resistant bacteria or sensitive bacteria. If you go to the ward and see a patient with a pneumonia, how can you tell this pneumonia is caused by resistant to antibiotics bacteria or sensitive? There's no easy, simple, and fast way. You have to take swabs, you have to take analysis to the labs, and actually you will wait for a few days, at least, until you get the analysis. And if you say you have to wait for response to antibiotics, okay, you wait, there's no response, but is it a cause, the resistance, that there is no response? Maybe there are other causes. It could be a viral infection, for example, or a fungal infection. And the speed and capacity of lab works are also very limited. And the non-binary conception, actually, You know, when we learned at medical schools, when we learned pharmacology, it was very easy. We classified antibiotics into the groups. This is bactericidal, and this is bacteriostatic. So bactericidal kills bacteria, and bacteriostatic stops them from getting more and more. But it's not like this anymore, because cidal or static, it now depends on the type of the bacteria, on the type of the resistance patterns in this bacteria. So I believe, and everybody knows this, that effects of antibiotics may be very different, not even in different countries, but in different hospitals within one country. So I believe in your hospital and in other hospitals in Colombo, there will be different rates of antibiotic drug resistance, and antibiotics will work differently. So actually, this is the invisible pandemic, and those invisible men, like by Herbert Wells, they are in every hospital, an invisible pandemic that kills patients. And no escape. This mnemonic way to remember the bugs, the bacteria that are most problematic, that was built from IDSA, the Infectious Disease Society of America, it's still there. In most of our cases, the resistance in antibiotics is Enterococcus faecium, MRSA, C. diff, Acinetobacter baumannii, Pseudomonas, and Enterobacteriaceae. It's E. coli and Klebsiella pneumonia. And I just wanted to show you that WHO, it published the global priority list to look for new antibiotics in 2017. And actually, up to now, we don't have a lot of new antibiotics. There's important thing here, that to research and develop the new antibiotic, it's very costly. In middle, the way from research to introducing the new antibiotic in clinical practice is $500 million. And what you get in the end, you get a new antibiotic, and after a few years later, resistance occurs. So bacteria get resistance to this new antibiotic. So kind of from a point of view of business, from a commercial point of view, it's not a good story, because pharmaceutical companies, they do it not for fun, they do it for money. When they do it for money, they think you invest, you have to get money back. So they better think they invest in cardiology or in cancer or in new psychiatry, treatment of depression, for example, because these drugs will be used for decades. A new antibiotic, you can get it to the market, and next few years, it's non-effective, so you lose your money. So the system of getting new antibiotics is not working. Just imagine the numbers. This is the large multi-center study that showed all the deaths in 2019 due to antimicrobial resistance. And you can see here the regions. So actually, South Asia, Southeast Asia, Eastern Europe are among the leaders. And in 2019, almost 1.3 million people in the world died because of resistance of bacteria to antibiotics. What are the causes? What are the diagnoses? It's pneumonia, number one, lower respiratory tract infections. It's bloodstream infections and sepsis. It's intra-abdominal infections. It's urinary tract infections, and it's tuberculosis. And when we compare causes of deaths, just imagine this number of deaths due to antimicrobial resistance, they are higher than deaths from HIV, from breast cancer, and from malaria. So every year, out of antibiotic resistance, more people die than because of malaria or breast cancer. So this is a friend of mine, Peter Collignon from Australia, and we had a great meeting with him at ANSI headquarters in France. So he addressed one important question: why the countries are quite different in antibiotic resistance rates. We have the same physicians, we have more or less same medical education, we train our doctors and nurses, but why in the countries of the same size, there are different rates of antibiotic resistance? You know, only 28% of variation between countries depends on prescription patterns. Interesting that it's overall depending on how the laws are working in the country. So if you add the indicator of corruption control in the country to the regression model, then it explains it in 2/3 of cases. So it means if the laws in the country are working, strictly and they are controlled, then you cannot buy antibiotics wherever you want. Just a question to the audience. If in Colombo right now, I will go to the pharmacy, can I buy ceftriaxone? What do you think? Would I buy antibiotic here? Maybe yes, no? Possibly. So when I go to the pharmacy, or no, I don't know. Maybe I'll try this today. I will go to any of the pharmacies in the center of the city and I try to buy antibiotic without prescription for money. And I'll check. I don't know. So maybe yes, maybe no. So actually it is important to control this. If you do the law that you have to control the prescription of antibiotics, you should control the pharmacies. And what we do in Belarus actually, if a pharmacy sells antibiotic without prescription, we take the license from this pharmacy forever. So we close this pharmacy, so there is no pharmacy anymore in this place. And people understand it, so the risks are very high actually. And this is the classification that should be on every table of a physician in every country. This is the classification of WHO called AWARE. So the antibiotics of excess, watch, and reserve. So if you want to go for reserve group, you need a phone call from the head of the hospital. So you had to make a call and say, dear head of the hospital, I need your permission to use colistin or to use linezolid. Yeah, and your signature, please. Because if you use them for free, there will be position when there are no antibiotics work in your hospital. So why I talk about this in context of microbiome? Because antimicrobial resistance, it happens not on the floor, not on the ceiling, not on the table. You can wash the table many times, but you won't find the antimicrobial resistance. It happens in the gut, in the intestines, because the concentration of bacteria in the intestines is the highest. And look what happens. So the left part is the normal gut microbiome, different bacteria in every body of you. Then you take antibiotics, and the sensitive bacteria die. You see only the red one remain. The red one is the resistant. And they start to multiply. And in the end, you have whole gut, whole intestines of the resistance bacteria. And this person, if it's your patient, he spreads it with their hands, yeah, everywhere, to the neighboring patient, to the doctor, etc., etc. So this is gut resistome. In your gut, you have genes of antibiotic resistance. Almost every doctor has them. That's important to remind. So you have to wash hands before surgical procedures. You have to wash hands after the patient. So this is why, because you can spread the genes. And what about cancer patients? I've been treating cancer patients for a long time in our Center of Hematology and Cancer and consulted as infectious disease physician, all infectious complications. You know, 2/3 of diagnosis of infectious complications in cancer patients, they're unsolved. Nobody knows the cause. So it's called febrile neutropenia because we don't know the etiology, we don't know the microbe. And day 100 after bone marrow transplantation, we do it a lot in Belarus, these patients unfortunately die because of bacterial infections. And the same story is in the United States. You see 26% of adults after bone marrow transplantations due to leukemia, they die because of infections. And you can see here in Belarus also gram-negatives, the pink and the red, those are the gram-negative bugs that actually cause the deaths in bone marrow transplant patients. So I hope actually that teamwork is not like this in Sri Lanka, because sometimes we see it in different hospitals where two head physicians, you see head of the department from one side and from another side, they build the railway, but the railway is not always the same. Actually, if you build a railway like this, it won't work. So we have to make it as a team together. And from antibiotic point of view, today we have only few antibiotics left, actually. So we have the last of the Mohicans, the carbapenems and colistin, and maybe inhibitor-protected beta-lactams like ceftazidime avibactam. And it's important to measure the colonization by multi-drug resistant bacteria in certain patients, like in patients with cancer, in patients who receive transplantation, etc., etc. Because basically, this is the risk factor. And the patients get infections from 2 points of entry. This is gram-positive from portal vein or from vascular access, and gram-negative from gut. So if we talk about vascular access, you have to be very careful, and you have to check the skin, you have to check the condition of the skin near the vascular access, because this is the main source of MRSA, of VRE in this kind of patients. Just imagine liver transplantation. We do a lot of liver transplantation in Belarus for our citizens and for foreigners. Foreigners come from different countries, and we do it for money. So rectal carriage of carbapenem-resistant Klebsiella pneumonia, it has a hazard ratio of 16, increasing the risks of sepsis after the transplantation, so 16 times more. Look at the development of new antibiotics. Remember, I said that pharmaceutical companies, they are not really into developing new drugs. Look, you see here the gap in the end from 1970 till 2000. Almost no new antibiotics were developed during this time because it's expensive. It's expensive, time-consuming, and not always cost-effective. And the lower part is when the resistance to this antibiotic developed. So you see here sulfonamides just introduced, the resistance developed. The same thing with streptomycin, the same thing with erythromycin, yeah? So the resistance develops very fast. Basically, bacteria are always ahead of us. So they do the step, then we do the step. And today, antimicrobial agents pipeline is actually very dry. So are there any other opportunities to control the infections? Yes, they are. One of them is bacteriophages, is the special viruses that are constructed to attack the bacteria. And we have experience in construction such viruses, yeah, but this is a strain-specific therapy. It's very interesting. And the other way is microbiome. So every new idea has something there in the back. So it's a forgotten old idea in a new variation. So this is the publication from 1964. It's published in Journal of Experimental Medicine by a group from Chicago. And it's interesting how they showed in the brilliant experiment how the antibiotics damage your gut microbiota and make you susceptible to infections. So they took mice, and they took Salmonella enteritidis, which causes salmonellosis. And they infected mice by number of Salmonella cells. So at some point, to infect half of the mice, you needed to have 10 in 6 degree Salmonella cells to infect half of the mice. But if you take antibiotic, streptomycin, and orally give it to these mice, and the next day, you need only 10 cells of Salmonella to infect these mice. So the immune system and the gut protection doesn't work then. The same with people. If you damage your gut microbes by antibiotics, then you're getting more susceptible to other infections. That's interesting. This guy here, yeah, Ilya Ilyich Mechnikov, Nobel Prize winner from Russia, 1908, the author of theory of immunity. So he's the guy who explained how the immunity of human being work, actually. And you know, he told that it is important that presence of bacteria in our gut, it protects us from other infections. And it can give you the longevity. You know here, this guy sitting next to Ilya Mechnikov, the guy in the long shirt, long white shirt and beard. Do you know who is he? Any idea? He's a famous writer, world famous Russian writer. It is Leon Tolstoy. Yeah, so it is Leon Tolstoy sitting with Ilya Mechnikov, world famous writer. Yeah, the author of the book War and Peace. You know, this is the great book about war and peace and all the battles. So if you want to read very beautiful about the battles, how the battles were going on, read Leon Tolstoy. He definitely understood the battle system, yeah? So he could write for 10 or 20 pages about the battle, how it goes on, how it stops, different stages of the battle. So they were friends, actually. And Ilya Mechnikov was 100 years ago. And what happens today? The most rich people in the world, they invest money in microbiome studies because they want to find the key to longer life in the gut bacteria. They want to live 120 years. They want to live 150 years. They have a lot of money. They want to live longer. And you can see here, Bill Gates, Zuckerberg, Mark Benioff, they invest millions and hundreds of millions of dollars in this study. And it's interesting, meta-omics analysis of elite athletes, they identify the performance-enhancing microbe that functions via lactate metabolism. What does it mean? If you want to run faster, you can take the microbes from the gut of a professional runner, transplant into your gut, and you will run faster. You don't need to go to the gym, yeah? So this is the future. You take the microbes, you transplant, and you become an elite athlete. You take microbes from somewhere who is doing cycling, transplant to your gut, and you are doing cycling better. That's very interesting that microbes can increase your physical endurance and stamina. And also, gut microbiome modulates response to treatment of cancer in melanoma patients. This is Israeli study. What they have done, that's a very beautiful study. They treated melanoma with anti-PD-1 drugs. And some patients did not respond to melanoma, had no response. So they were dying, actually. So what they've done, they found a group of patients who responded to treatment to melanoma. They took their gut bacteria and transplanted to the non-responders, and then retreated the responders, non-responders, once again with the anti-PD-1. And what happened next? The non-responders responded to the treatment because of the different bacteria in their gut. That's brilliant. And this guy, this is academician Alexander Ogalev from Moscow. He actually invented the theory of leaky gut syndrome in 1985. So he was a famous trophologist and gastroenterologist, and he said that our gut, the lining of mucus of our intestines, it's not like a brick wall. It's not an aquarium. It lets some molecules go into the blood vessels all the time. So bacteria, parts of bacteria, lipopolysaccharides, they get into the blood vessel. And that's chemicals, they make us feel worse, actually. So if you feel yourself worse from the morning, for example, exhausted or tired, just think, maybe that's because your bacteria in the gut, they made more lipopolysaccharide to go into the vessels. Once again, citing Hippocrates, the life and the health, it lies within the gut. So microbiome is big data. We do the molecular sequencing. We do a lot of molecular typing of microbiome. And it looks like this. This is Vasily Kandinsky, world-famous artist, abstractionist. This masterpiece is called Without a Name, because nobody can tell what actually is there on this masterpiece. Each of you sees something different there. But when we talk about microbiome, this is what happens when we take the microbiology swab and try to culture your smartphones. We take your smartphones, culture, and that's what we see. Those are fungus, actually. Yeah, there's a penicillium fungus or something this. But when we use proper methods to study microbiome, those are molecular sequencing. We can find the rest. We can find the other rest, 60% of bacteria that don't really grow in the media. And 40% is the dark matter, you know? It's something that we can sequence. We get the genes of these bacteria, but we don't know the names of these bacteria, the function of these bacteria. It's like dark matter in the space. It's some kind of material there in our gut. We don't know. Are they bad? Are they good? So this is the question for the future research, for the future science. Because there are numerous uncharacterized and highly divergent microbes which colonize human, and they're revealed by circulating cell-free DNA. We don't know these microbes. There are many of them. So we shall, in the future, understand which of them are together with us and which of them are against us. Because what we look for and what we get really depends on the method. We use culture, we get only part of microbes. We use metagenomics and 16S profiling, we get all the rest. Once again, this is masterpiece. You can see only the lower part by culture, by classical microbiology lab. But if you do the sequencing, if you do the genotyping, here you can see the whole bunch of microbes. By the way, this is very famous masterpiece by Joan Miró. Joan Miró is a famous Spanish artist. If you've been to Barcelona, in Barcelona, a lot of things in museums by Joan Miró. And this is called the Carnival of Arlequin. So this masterpiece is 100 years this year. And this is what we see really in the gut. Different microbes. They contain anaerobes of low pathogenicity. Most of them are anaerobes, so they live without oxygen, and they will die if there's oxygen there. And aerotolerant low pathogenic bacteria of clinical relevance, they're also there. If you ask me the question, so you use antibiotics, but how to protect the gut microbiome from the damage? Yes, there are some ways, actually. One of the ways is selective sorbents. They're in the late stage of clinical trials right now, is the sorbents that sorb the antibiotic in the gut. So it has some effect on the system, it goes to the vessel, but the rest of it in the gut is sorbed. And the FMT, fecal microbiota transplantation, it's transplanting the poo. You know, it may sound very funny, but it saves lives actually. And when you go to the history, in the history, it's very ancient method. In the ancient Chinese manuscripts, the manuscripts that are over 2,000 years, you can find a special treatment that's called yellow soup. It's how the ancient Chinese treated diarrhea. What they've done, if you have a diarrhea, then you take poo from your wife or your husband, normally from someone who lives with you. You filtrate it through the special paper, filtering paper, and then you drink it. And drinking it, you stop the diarrhea because what you drink, it contains good bacteria. So ancient Chinese called it the yellow soup. And now we call it poop in a pill. Actually, that's how they treat right now, and many countries treat Clostridium difficile diarrhea. Just wanted to show this graph here. It's very interesting. So in this graph on this right side here, you can compare the different curation rates on different treatment. So on the right side, it's the standard of care, vancomycin, to treat Clostridium difficile. And on the right side, it's infusion of donor species. So the efficacy of vancomycin is 30%, and infusion of donor species is 93%. Even this study had to be stopped because of the ethical issues, because patients in the group of donor feces were surviving, and patients in the group of vancomycin were dying. So this is a very effective procedure, and the fecal transplant, actually, it can be done as an enema, as a capsules, endoscopically. So we often do it in a capsules. So this fecal transplant, it's been put in a special acid capsule and freezed in a refrigerator up to -53. And then it's like an ice cream. Yeah, it has no smell. Yeah, it looks just ordinary, and people take it as an ice cream, and they survive. So this is the new treatment for old microbes, and this paper in the New England Journal of Medicine, it's already more than 10 years. It opened the road for fecal microbiota transplantation. And look, these are the European guidelines to treat Clostridium difficile infection. And you can see here, this is the guidelines of European Clinical Microbiology and Infectious Disease Society. I'm a member of the society. So standard of care for initial CDI is vancomycin, but if you have recurrence, the standard of care is fecal microbiota transplantation. So it's a standard of care today. But we can go further. We can figure out which microbes out of this fecal transplant are the best. So we figure them out, and then these 4 species, yeah, you can see them here, yeah, those are the guys that actually fight the Clostridium difficile. You know, Clostridium scindens, the last one, it's very important. Clostridium is like a large family, and in this large family, you have a bad brother, you know, like in almost every family you have a bad brother. Like good sisters, good brothers, and one bad brother who drinks, smokes, he doesn't go to job, has no money, and every family tries to cope with this bad brother, you know, like try to say like, go find a job, please do something good. So this is Clostridium difficile. He's a bad brother. And Clostridium scindens is a good brother. So when a good brother is near, he will control. So no infection will occur. So it's the example how bacteria, good bacteria, try to control the bad bacteria. Look, those are the good bacteria on the left-hand side and the bad bacteria on the right-hand side. So what we do, we can find the good bacteria, make the cocktail, and make a patient drink it. And the good bacteria will make this bad brother become more silent and more calm. That's the future, actually, and that's called the post-FMT era, what's happening right now. We are going from fecal microbiota transplant to microbial cocktails. And as a clinician, there are three principal red flags of gut microbiome that we can use in clinics. It's metataxonomics, the proteobacteria phylum, metabolomics, short-chain fatty acids like acetate, propionate, and butyrate, and the biodiversity of the microbiome. Biodiversity is very important. It's like in the society. In the society, you have men and women, you have older and younger, yeah? You have poor and richer people, you have better educated and lower educated people, and it's good because you are different. You have doctors, you have officers, yeah? You have builders, you have engineers. So when the society is diverse, then it's effective. Just imagine if your society would contain only old people. No children, no teenagers. Would it be efficient? Not really. The same with bacteria. So this thing is called the microbiome passport. This is the thing that actually we invented with our colleagues. So this is the whole story of a patient with a cancer, with leukemia, who went for the bone marrow transplant at a hospital. So we published it actually in the Clinical Infectious Diseases, the top journal in the world in infectious diseases. So on the top is all the drugs that were prescribed to him at the hospital. So you can see here chemotherapy, ciprofloxacin, antibiotics, etc., etc. And then goes the leukocyte count, the white blood cells. So he went to neutropenia. Then goes the fever. So you can see the spikes of the fever in this patient. And there you can go the blood culture, E. coli. And on the lower part is the microbiome analysis. So the more colors is in the stick, the more different bacteria he has in his intestines. And when he starts, he has a diverse gut microbiome, very different. But then, on the treatment, his diversity goes down. The red part is E. coli. So E. coli starts to dominate, multiply in the gut. And already at this part, a week before, we know that this patient will develop sepsis. So we can predict sepsis a week before the sepsis develops because we analyze the condition of the gut microbiome and we tell that this patient will have E. coli in his blood and he will have sepsis. That's what happened next, sepsis. And then we used antibiotics to treat sepsis and then microbiome destroyed, and the green one is Enterococcus. So Enterococcus took this place. So you see, we can predict a lot of things in modern medicine, especially gram-negative infections. Liver transplantation. I know that you do liver transplantation in Colombo. We do quite a lot of liver transplantations. You know what's interesting? Different patients receive liver, and in some patients, liver rejects liver graft, and in some patients, no. And they have the same regimen of chemotherapy, they have the same regimen of immune suppressants. What happens? Why? You know why? We published this in Journal of Liver Transplantation recently, my team, and it's interesting that gut microbiota inside the intestine, it is connected to the risk of rejection of a liver graft. So it means that there is an immune interplay between immune cells in the gut and bacteria and the risk of rejection. So actually the answer of liver transplant rejection is within the microbiome right now. It's the future. Why it is important for us? We do a lot of organ transplantations in Belarus. We do kidney, liver, heart, lungs. We do bone marrow, really a lot. You can see the numbers of patients transplanted per 1 million population in Europe. So we have 51.6. It's higher than in Poland, in Russia. Yeah, it's higher than in Germany, actually. What's the answer? We have skilled surgeons, and also we actually have the opt-out system. It means that every traffic accident, we can take organs. So organ donation is very easy because the system means that every citizen, by fact, if he dies accidentally, doctors can take organs, kidneys, livers, etc. If you don't want this when you're alive, you go to the center and write refusal. It's called opt-out. So there are some people who opt out. As I know, in Sri Lanka, there's opt-in system. So it means if you want to donate an organ, you have to go somewhere and write a paper that you want to donate. So it makes it harder for you to get organs for donations. So if you go for opt-out, like Belarus did, yeah, you'll get your transplantology go up. So actually Spain has the same story. Spain has opt-out, and they have a lot of transplantations. And the short-chain fatty acids, these chemical compounds, they fall down the same days when you have the E. coli grow up. So these protective compounds, they fall down. Sometimes I have a question about little children. Why some of the little children fall ill with respiratory infections very frequent and some are not? The answer is also within the respiratory microbiome. It's interesting that if we show the children in different groups, so the green group is children that have 1-2 respiratory tract infection episodes per year. The second group, they have more, 3-4, and the right group, 5-7 episodes of infections per year. They have very different bacteria in their pharynx, in their mouth, very different. So these green ones, those are protective ones, the ones who produce the short-chain fatty acids, acetate, propionate, butyrate. It means that they protect these children from viruses. And the right ones, the red ones, they do not protect. So kind of understanding the microbiome of mouth in these children, you can say if they fall ill often or not often. And the red flag number 3, biodiversity. I said it already. So more than 8,000 samples from different countries, United States, Europe, Japan, and actually we showed that a patient who have lower diversity of microbiome in their gut, they have more chances to die after transplantations. All over mortality was definitely higher. And after transplantation, of course, diversity decreases. So we have to think further. Dear colleagues, we have to think further because our evolution rate is very small. But the evolution rate of bacteria is much higher. Look, staph aureus, 8.5 mutations per genome per year. Yeah, so strep pneumonia, 3.5. Helicobacter pylori, many mutations. So bacteria, they're always few steps ahead of humanity. So they run forward and we run towards them. It's like Alice, remember Lewis Carroll? The Red Queen, yeah? What did the Red Queen say to Alice? She said, in this world, to stay on the same place, you have to run fast. And if you want to go somewhere, you have to run twice as faster as you are. So we have to run very fast to get the speed of bacteria. And of course, the evolution of viruses. Every pandemic, virus evolution is very fast. That means that we have to be faster as a scientists to develop new drugs, new vaccines. And one of the important questions to tell is how fast we are right now. This guy here, very famous one, Gordon Moore. Do you know what's written near him? What's the name of the company? Intel, yeah? I bet that most of you, when you open your laptop, your computer, open it there, you look for Intel. Oh, even in my laptop here, I see Intel Core i3, yeah? So this is the founder of Intel Corporation, the largest company to produce processors. And processors actually is something that really is in charge of memory, but not also memory of data analysis. So how fast can you manipulate and analyze the data? And he introduced the Gordon-Moore law. This law from 1965, it means that every 2 years, the number of transistors on the processor it goes twice, every 2 years. So from transistors and processors in 1970s, you see, till current times, the processors in the computers are very fast. What does it mean? The price, the cost of sequencing and molecular genotyping, it will go down, and it goes down, and the speed goes down. Look, this is the cost of sequencing of human genome. In the early 2000s, it was tens of millions of dollars to sequence the genome of a human. And right now you can see, by the Moore's law, you can sequence your own genome right now less for $1,000, just less than $1,000, and it's full sequence, you know, all your genes. You can say all your risks of any disease. You know, you can tell all the ethnical groups that are in your genotype, like 3%. Yeah, I've tested my genotype actually. I was very interested what nations are there back there, like 10 generations before me. So it was very interesting. So I recommend you, if you want to know your family history, what nations were there, maybe 10 generations before, there were some interesting nations in your family. So that's why this method I show you, the sequencing of microbiome, it's getting into the real life clinical practice. We've published this in All Life journal in 2022. So we introduced the real life clinical sequencing practice in our bone marrow transplant center. And in the end, I would like to say thank you to all of you, and especially to Your Excellency Admiral, and to say thank you for having this great lecture at this great day, the 9th of May, the day of victory, and the day of establishing our memorandum of understanding and our partnership with your beautiful university. All the respect from me to your faculty and students. Thank you.
Thank you very much, Professor, for that very detailed lecture, and we appreciate you for being here. Ladies and gentlemen, it is now time for the very significant moment that all of you have been waiting for. We will now be presenting the plaque to commemorate the initiation of this Memorandum of Understanding between the Kotalavala Defense University and Gomel State Medical University. For that, I'd like to invite now onto the stage Vice-Chancellor of General Sir John Kotalavala Defense University, Rear Admiral HGU Dhammika Kumara. Sir, you are now invited alongside our Chancellor of Gomel State Medical University from Belarus, Professor Igor Oligovich Stoma, in order to present the plaque and signify this momentous occasion. Ladies and gentlemen, during a time that the world is changing and evolving, this is a very, very important day. Can we have a big round of applause from all of you to commemorate this? The plaque is ready, and now, for the very momentous occasion that we have all been waiting for. Let's give a big round of applause, everyone. Today, the 9th of May, 2025, marks the initiation of the MOU between General Sir John Kotalavala Defense University and Gomel State Medical University. Thank you very much, gentlemen, for joining us. We'd like to please give them another round of applause, shall we? Thank you very much. No end is actually an end. This end of the event will mark the start of something much, much bigger. During the time where the entire world is currently going through crises, different military crises around the world, different medical crises around the world, we have all come together for a very momentous occasion to share not just knowledge, but to share where our futures will go. For that, ladies and gentlemen, you have all attended this CME and the initiation of this very special MOU. And to wrap things up, ladies and gentlemen, we will be, of course, going into the national anthem, and after that, we will begin the press conference of this very momentous day. Ladies and gentlemen, please rise for the national anthem of Sri Lanka.